neuroimaging part with various diagnostic devices, includes MR and MA, predominantly on the MR side, because I worked with MR for the last 20 years. Yes, it's a short intro of mine. I always start with this. Yeah, I have like PhD in biomedical engineering from IIT Madras, and prior to that, MA from Anna University, instrumentation background, and BE and I from Annamalai, Chidambram. Overall, I have around 20 plus years of experience in R&D industry, all in MR, and I'm specialized with MR guided therapy solutions and general MR imaging and echocardiography from my PhD thesis. My hobbies are travel and photography. The pictures that you see in the bottom are the projects that I'm working on. From the left is of initial time, like from masters on the phonocardiogram, and then I moved to echocardiogram and my thesis, PhD thesis, and all other images that you see are like from my work experience with GE. It's like all with GE and Philips, I would say. So it's like all MR scanners, but with specialization on the therapy side. How MR can be used in terms of therapy as well as a guidance. There was a question or something. I saw a ping.
Yes, someone has raised the hand, please. No, sir, we will continue, sir. Yes.
Okay. So I work in the area where MR can be used as a therapy, as a guidance device in terms of therapy. So I wanted to share my experience here around that part. I see a raised hand from Sajita Nair. Okay, maybe I can keep going. If it is a false alarm, you can stop me. Okay, I structured my presentation around this. Like I split it into 4 groups. One, let me start with what is neurodegenerative disorder, and then with picking up the 2 prominent one, or the interested one that at least interest to me, and what are the diagnosis methods available, that is the devices, and I want to go in detail about how it can be cured, or like there is some treatment from the therapy as well. When I say therapy, it is beyond diagnosis, which is very uncommon. So I want to share that experience here, which will be of more interest to you guys. So please stay online till the end of the course. Okay. What is neurodegenerative disorders? As the name suggests, yes, it is a degenerative, and it's something related to the neuro. So that means the main part of the neuro, it's a neuron or nerve cells. Something is happening there, which is not working the way it is expected, and that's causing a lot of issues. Yes. So basically, it is a condition that affect the nerve cells. When I say nerve cells, you have studied that neurons as a functional or the fundamental unit of the nerve system. So something wrong with the nerves, or something wrong with the transmission of signals between the nerves. That's what all put together. It's called neurodegenerative disorder. This is a umbrella of terms, but this includes a lot of diseases. It's not one. And yeah, we can see in detail. But yeah, this is the main causes of the problem this causes the problem in the movement or mental functioning, because the neurons or the nerve system is very critical for the human being across all the verticals, like be it thinking, be it walking, be it any normal function. If that is affected in any manner, it will impact all the functionalities. Yes, and it causes a permanent damage. It will get worse as and when we progress. That is the sad part of these disorders, and none of them, or almost all of them, don't have any treatment. We only have the solutions that can delay the delay the end, or maybe to slightly improve the lifestyle, but there is no cure to that, to many of the diseases actually, because it is a permanent damage to the nervous system. Yeah, I just put this picture. You know this very well, but just to get in context, this is a spinal cord where you have a 3 segment, or 4 segment rather, CT, L, and S, cervical, thoracic, lumbar, and sacrum. You can see the nerves coming from this spinal cord. On the right side picture, it's going to the brain, and it's controlled by the brain. It's the master of the nervous system, as we all know. And the below picture is the neurons, where I put 2 neurons which is connected to each other, and through which the communications or the signals are getting passed, which means the command to do some certain action, or to respond to an action, those things are getting passed. And based on that, the muscle will do the voluntary or involuntary actions that you guys know. Just wanted to put the picture here. Okay. Okay. So I like what are the symptoms? And in the previous slide, I said it is not one disease; it is group of disease. But almost all the disease of this neurodegenerative disorders will have almost all of the symptoms. Basically, anxiety, loss of inhibition, agitation, apathy, difficulty with the movement, forgetfulness, memory loss, mood change, tremors or shaking. It is just the degree of each of them will change between the diseases, but almost all of them you can find in any of the person who has an issue with the nervous system or the neurons. So it's very hard to differentiate between this. Say something like Parkinson guys will have only this, Alzheimer's person will have only this. It's not that straightforward. So that's why you put as generic symptoms. So if any of this are started appearing with anyone, it is better to go to the checkup or like go to the medical assist as early as possible. That was the request or ask from the people from the medical world. Yeah, I said it's a group of diseases. It's not a one disease. When I say neurodegenerative, it's a group of disease. Some of them are here. I mean, like I listed here. The prominent ones are like I listed here, like Alzheimer. Basically, it is a simple memory disorder, and amyotrophic lateral sclerosis. So basically, it's again the motor neurons slowly die. It's basically a problem with speaking, or movement, or breathe, or eat. Basically, the movement, the speak, something into the mouth. Huntington's disease. So basically, it is the other side. It is not difficulty, but it's like it move uncontrollably and changes in behavior and think. It's like there will be the swing will be more. It's very hard to predict. Parkinson's again, this is one of the prominent disease which you will find most of the population with in United States predominantly, and also the Alzheimer's. It's an age-related condition, and again, it causes the tremors and balance issues. The next one is the multiple sclerosis. This is basically autoimmune disease. So when the immunity system is affected, and it causes a lot of things, especially when the immunity of the nervous system is affected, it causes a lot, and it causes total body weak, and the deterioration will be more and it will be at faster rate as well. What are some other types? Other types of diseases, ataxia. Yeah, you might have not heard of this, but just want to put that here. Ataxia, Friedreich ataxia, Lewy body disease. So it's just a note here, just for the context. Nothing, it's not going to the detail. The one I'm going to talk about is two diseases here, Parkinson and Alzheimer's, because of prevalence in the world, and because of the severity, how it affects the quality of life. It affects dramatically the quality of life. So I want to focus on these two. Any questions so far? Let me know. We'll keep going otherwise. Yes. Parkinson disease. Yeah. If we see the symptoms, it is like a tremor of resting muscles, rigidity, bradykinesia, basically the slowness of movement, impaired balance, and shuffling gait. It's like too much of detail in English, but at simple, they cannot walk, and all the body parts will be shaking because of that they could not walk steadily as well. They cannot do any action on their own. Even they cannot take a glass of water and drink without spilling it to that level. This will affect the quality of life in the society a lot. And yeah, so this is problem with most of them, the age related problem, and you'll see very huge, like about there is a statistic says 35% of people aged over 80 in the US are having this issue, this disease, which is too much, very huge. Yeah, unfortunately, we don't have any cure for this, but there are a lot of techniques. I'll talk about that later. But there are a lot of techniques which give a temporary relief and will improve the quality of life in the society, so that they can mingle with other people as well in the society. Okay, what is the reason for this? This is very specific, actually. Like each of the neurodegenerative disorder are like very specific to certain function or certain organ in the brain. That is, I must say here at this point. So I listed a huge number of diseases because the brain is complex. Each part of the brain or any fault with any of the small part will cause all any of those diseases. That's how it is. For example, Parkinson. There's a small part, substantia nigra, in the body, in the brain, the red color spot, as you see here in this picture. The small part in that area, the neurons talk to each other through a medium, which contain the dopamine. So this chemical is as a medium which communicate the functions. In case of Parkinson, the communication between this neuron and the outer side of the brain, there's a corpus stadium, we call it as, dopamine became lacking here, which means brain thinks something, but that is not communicated fully to the outside the brain. What it happens is, if you keep passing the message, only 10% of them will go, remaining will get destroyed. So that means the body will don't know what to do, so it will become confused and become all those vibration tremors will comes here. That is the main reason for the shaking. Brain thinks, or ask the hand, or like for example, if you want to take the bottle of a glass of water, the brain commands the hand to take a glass of water, but it is like bits and pieces, it get lost because of lack of dopamine. The commands keep coming in parts, so that's why the hands are shaking here. That's how I could put it here, I explain here. Okay, next is Alzheimer. Yeah, Alzheimer is it's slightly different variant. It is basically loss of brain cell in the area of the brain. Basically, it's like a wherever the brain cell dies, it loss, and that creates Alzheimer disease. But how does it happening? So basically, because of, again, the messages, the chemical messages between the neurons. But unlike the previous type, here it is not a dopamine, but due to the presence of two things, which is called amyloid plaques and neurofibrillary tangles. This is nothing but, see, you would have heard plaque is nothing but a piece of thing that comes in block. Let me show the picture here. So one on the top is a Microsoft picture of the normal brain neurons, and one on the right is the with those symptom with Alzheimer brain. What is different is, you see some plaques here, amyloid plaques between the neurons, and within the neuron you see something called the neurofibrillary tangles. Basically, the neurons are like it's tangled, meaning it's not straightforward. So that if you're passing a wire in a bunch, if you're passing a current to the bunch of wire, if it is tangled, you won't get any signal at the end of the wire. It will cause a fuse or it will cause a burn. So that's how it is. I put that. Basically, the transmission is affected because of the neuron itself. That's called the neurofibrillary tangles, and plaques that comes between the neurons. That's these two causes the deterioration of communication and the neuron itself, the cells itself, and it dies eventually. This is another picture in the bottom one. This is a closer look, but no need to look into that. It's a bit confusing, but the right side pictures clearly shows. The left is a normal brain where there are two neurons happily talking to each other. But whereas on the right side, you see the neurons, there's a plaques, and also the five related the tanglings were there in the head part of the neuron that causes the defect again. Yeah. So these are the two diseases. Now we know why it is causing. One is because of lack of dopamine, where it acts as a medium that was lacking, and other part because of degeneration of cell itself. That is because the neurons itself, because of two additional things, like two things. One is the additional plaque, and the other one is the way it was designed or structured in the head of the neuron. So these are the two diseases I'm going to talk about in detail. Any questions before I proceed on this? Okay.
Sir, especially the protein biomarker, like beta amyloid in case of Alzheimer, alpha synuclein, tau protein. So specifically, these protein biomarkers are taken in clinical real-time applications. In
Yeah.
research,
So,
we are considering.
mhm.
In real-time applications, these protein biomarker SBR values are really taken into consideration.
Yeah, so how we do is basically in the yeah, obviously the first level of test is directly doing the lab test or biopsy test or doing getting to find this level of this contents. The other option is the 2D imaging, that's a MR or CT. You do some special techniques in the MR and trying to find the markers from that. So the presence of this will show a different behavior in the MR images. So that's why we are trying to identify from the MR images actually.
Thank you.
Yeah. Can tell me any biomarker which will help me to find. Okay, I think the both the questions are pretty much similar. So the biomarkers, there is no gold standard. I would say at least that we are not heard. I'm not heard of at least. So there are a lot of research happening in the MR side at least because where I am involved. People try to do special type of sequences and get the image and trying to correlate, try to find the biomarkers. But having said that, in the because of evolution of the AI in the recent times, people are blindly going for the AI. I referred a paper here. Maybe you can take a look at it later. That contains the latest trends, how to find the biomarkers or how to find, I mean, the degree of Alzheimer or Parkinson, any neuro disorders from the image using AI or ML algorithms. That is very nice paper. You can take a look at it. Actually, in short, people are tending to going towards the AI and ML instead of finding a specific biomarker. That is like the last decade trend, I would say. Does it answer? Hope so. Let me know if not.
Yes, sir. Thank you. Yes, sir.
Yeah. Okay. Diagnosis method is methodologies. Yeah. So now that we know how will it help autism disease also? Um, See, autism it is yeah, in broader you can say as a disorder, but it's not something coming in the middle. Like it's not something changing after birth. It is like coming. It's like a birth defect, I would say. So there are not much MR studies at least. Perhaps I can try to find that and get back to you on this one. Okay. Yeah. So now, so far I explained the two diseases at least, how it is happening, why it is coming. Let's see what are the methods available. I'm going to focus more on the imaging side, but yeah, I just wanted to give a brief on what are the other techniques available. It always starts with a basic test, that's psychological neurophysiological assessment. Basically, it's a simple questionnaire, and there are a lot of tests that are available. I'm surprised to see many actually. I found this. I know there are tests, but I didn't go into the detail. But as part of this preparation, I got to know many more of this such test. You can take a look. This is the paper I was referring to. This contain it asks simple questions about the symptoms, just to check the repeatability of the answer that you get from the patient and the accuracy of the answers you get from the patient. Basically, these two are compared and scored against different criteria. That's called like a visual short-term memory binding test, Wisconsin card sorting. There are many more actually. I could not put that here, but there are many more. That is one simple assessment. The next assessment is the neuroimaging. You go to a 2D scanner and do the scan. And there are two modalities which are predominantly used: PET-CT and like a MR. I'll talk these two in detail. And there are some another way of studying about excuse me, by studying the electrical activity of the brain, basically nothing but EEG. And yeah, the people find some difference in the EEG pattern between the normal and the abnormal, but there are some challenges in getting that. One is because of it's the type of defect is distributed in different part of the brain. We could not correlate to particular behavior of the EEG to particular disease. So, but there are a lot of work on applying AI on the EEG with this diseases, trying to find that. Okay, there is a question. Do we have any papers, reports on statistics related to the patient number with respect to disorders in India? I tried. I could not find any specific to India, but perhaps we should be able to get because the probably one of the reason is we don't find this two diseases more in India. It's very rare. You see, like in your town, maybe you will see one or two. That itself very hard to see. But in US, it's not the case. Every street you will find two people there. So that's why we don't have any data in India. But yeah, I haven't seen one at least. There is one more question. Yes, BK, please go ahead. Okay, I'll keep moving if it is a false press. Okay, I'm going to talk about these two neuroimaging technique since the given topic was around the imaging and I'm working with the imaging modality. I would start with PET. PET stands for positron emission tomography. Yes, so this is like something emitting from the body, but how? Let me give a brief. I'm not sure. I'm sure like many of you have heard of it, but I just want to start with giving the basics how it works, and then I can get into the detail of it. Yeah. Before that, yeah, we have MR and CT. Why do we need to go for PET? Yeah, the main benefit of CT and MR, yes, you'll get the structural, and in MR these days we are getting some functional, but that's not a standard. It's always crucial to get a real functional imaging of the brain behavior, and that's why we need the functional imaging, the pure like a gold standard functional imaging. And the PET system, PET acquisition is one of the crucial or the gold standard, I would say, and that is important, especially in case of neuro disorders. Okay, how does it work? I'll just give it. I won't take much time, but yeah, please stop me if you have any questions here. Okay, we all know ATP is a powerhouse of the body, and how does it form? The cells pick the glucose from the blood vessels. The red one is the blood vessels, and the glucose we see here. The glucose that is part of the blood, it is picked up by the cells and go for metabolism and create the ATP. ATP is adenosine triphosphate. That's a powerhouse to for all the activity. It's like a outcome of the metabolism. But yeah, how do we have the PET imaging? What did our scientists did? Our scientists created something called like a glucose, but with an isotope in it. And one of the example was 18-FDG. This is an glucose plus isotope component. So the how it works is this FDG is 18-FDG is injected to the human body before the scan, and a patient were asked to wait for 30 minutes or so. By the time this is circulated throughout the blood vessel, throughout the body, and so what happens here is this cells will always pick the glucose. The cells also thinks this also, yeah, it is a part of glucose but with isotopes. So the cells also pick this 18-FDG in addition to the normal glucose, and it builds the ATP. So what will happen at the point of time when any cells pick the 18-FDG glucose? What happens is the protons get emitted from this isotope that is part of the 18-FDG, that is E plus, and this proton interact with electron of other molecules surrounding the cells. So these protons and electrons collide and form a gamma rays, and this gamma rays goes in exactly in opposite direction, one on the top side, one on the bottom side, and that gamma rays is picked up by a array of detector that is part of the PET scan, and the detector is used to image to get the activity. And this is called a coincidence imaging as well, but this is like more of a generic term. Let's not get into that. Okay, so yeah, I got it. So I injected 18-FDG and I'm doing the cells pick it, and the gamma rays are passed. Then how do I differentiate between the good and bad cells? So there are two scenarios. When there are cells are good, that means it's active. The metabolic activity is more, it's very high. What it means is there will be a lot of glucose intake and 18-FG intake as well. That means there are more gamma rays emitted in that location. As you can see, is the bright spot of the image. Similarly, on otherwise, if metabolic activity is low for some reason, yeah, the intake will be low, and you will get a low intensity here in the image. So this will give an indicator of where the metabolism is more, where the metabolism is less. From that, we can draw a line. Okay, is it normal or abnormal? What's happening there? Suppose, let's pick an example. So there is a cancerous area. Let's say there is a liver portion, and in the cancerous cell, the metabolic activity will be always high. That means there is more intake, and it produces a bright spot here. So if you see here, this is in the liver area. This shows a cancer cell in the cancer region in the liver. You see the bright spot here. Yes, this is the basics of very basics of PET imaging, how it works. I just want to put that here and going with that. Okay, I see a couple of questions here. Why not we go for fMRI as it also captures functional activity of the brain? fMRI is I mean, the PET scan is a gold standard, I said, but people are also making use of fMRI these days. But again, the gold standard is a gold standard, nothing can beat it. fMRI they use for a preliminary, but still they'll go for PET at the end of the day for confirmation. Any side effects of injection or of injection of the PET? Yes, it is. There are some side effect. We cannot doing for PET scan more. It is ionizing radiations as well, so it is not recommended. It is there are side effects as well. Yeah. Coming back to this, yeah. So okay, so I injected a 18 FDG. I got a white spots. Now I differentiate where is a cancerous or where is a abnormality. Suppose if it's in the brain, if there is any lack of region, I'll get some different spot. Would that be sufficient? No, because if you look at the image, it is very noisy. You cannot make out anything out of this, or like you cannot get the crucial information out of this. So the typical how it works is this PET scan will always be done together with the another scan that gives the anatomical information. For example, CT. So it's always done with the CT or MR as a like a both has to go hand in hand. First they will do the MR or CT. They will take the full image metrics, and the same patient is repeated in the PET. Both images are registered to map the PET map over the anatomical information to get the localization clearly. Is that simple? No, but I'll come to that. But yeah, this is how it looks. So this is a PET image. This is a CT where it give the morphological information, and you do register of these two. You'll get the PET information overlaid on the anatomical information where you could clearly see okay which part where is the hypo intensity, how where is it showing. You can see that clearly here. Yeah. Okay, some of the PET images. So you can see the hypoactivity here in case of Alzheimer, and same here in the top row are normal, whereas in the bottom two are with the diseases where you see the hypoactivity. There is lesser activity. You don't see more color here. That means less activity here. The sample PET images. Again, this is another example. I just want to show that because it's very hard to see the PET image like MR image outside world. So yeah. Okay. I said there is a PET imaging, and we need to use a modality that gives the anatomical information as well. That will be CT. We have two options. Definitely not ultrasound because that is worse than PET, I would say. So people go for CT or MR. Okay, where should I go for? Yes, CT is good for a special resolution. You can bone imaging the bone. It will be very cost effective. It's easy to do trauma and emergency surgeries. While MR has its pros as well. This give an excellent soft tissue contrast, such as we can differentiate between the different ligament or organs, fat. That option is not there in CT. CT will give only the black and white, bone and not bone area. So that's only that is possible in CT. And MR also give excellent contrast, and you can image any organs with no limitation. And last but not the least, it is a non-ionizing, so it is good to you can go multiple times in MR, so it's no issue with that part. There is no side effect. So, but there are some challenges. I'll come to that. By default, PET go along always with the CT. That was a legacy way of working or classical way of working. PET CT is commonly called as even PET, but PET MR is something new, I would say. Like, but yeah, I'll come to that anyway. Yeah, when I say PET MR, there are two things: doing PET and MR, that is PET plus MRI, and PET MR put together. I'll show that a couple of videos here. Before that, I'll see if there is any questions here. Any possible situation to get false positive results from PET? Yeah, that's little bit of risk, or like the failure is there with any modality. But yeah, all those things has been taken care. Even in the MR, if there are some scans to detect a lesion, there is a possibility that it could show up, or we could miss that lesion, or we say something it's normal, we call it as lesion. So certain amount of risk is always there, but nothing beyond that. That risk also very minimal. Okay, I'll show this video. Okay, I'll not. Those two machines could not coexist in the same room. So in the whole setup, so the both the machines like located in the same room. So what you see is a MR. First, the MR scan is done. Once MR scan is done, the table is rotated and get into the PET scan. So with the MR, you got the morphological information. That's what he's showing. And since the patient is not moved while switching the table, so the landmark and the position reference, everything remains same. That to have two modalities acquired practically you can see the PET map overlaying on the MR. Of the images. The fact that we have the two modalities together, separated by one bed, of the scanners. So this is the actual picture. Exactly the MR is done, and the patient is rotated to move into the. Requires the patient to stay still. The bed moves from one scanner to another, and then images are being superimposed. Advantages are that for the patient, it's a shorter acquisition time. He gets two studies done, MI and at same location, allowing them to be. I'm not sure if you guys notice that it was told that the patient were asked to stay idle, where there is no control mechanism, but we are just asking them to stay. Yeah, so let's come to the benefit here. Yes, back-to-back imaging all in one session. There is no additional time, and patient decision is good because we ask the patient to stay still. But in reality, but yeah, this has not become 100% effective because we never know. Are they still? Are they moving? Are they moved? If they moved, then registration will go for a toss. There will be misalignment. So those are the challenges with this type of approach. So that's when people did more research and they found something called a PET MR. It's not PET plus MR, it is PET MR. I'll show this picture. So this is the detector, the PET detector. It's a wheel, and this is built inside the MR. So the bigger cylinder is MR cylinder, MR coils. So the PET plus MR are put together. Yes. This is outside it looks MR, but you can see a special patch. This also has the PET receiver. So that means this is real PET and MR. It's not PET plus MR. So this has a lot of benefits. Includes it's all in one imaging. Patient is not moved, it's not pulled out, it's not rotated, and there is no registration issue, and lesser scan time, very good motion management. So for example, if there are something if there are any like let's say Parkinson, they're doing some head scan, and I earlier said that it will be shaking, a little bit shaking, but as a precaution it will be tied with the wrap with the belt, but in spite of that there will be a little bit motion. All those motion we can overcome by using the techniques that's available with MR sequences. So this is a powerful solution. There are some drawbacks, but people are overcoming it. This is a very powerful solution as on date in the market. Can we put two devices near they make any hardware issues? No. That is the specialty of the development. That is the area I'm working on, where we combine MR with ultrasound device, MR with PET device, MR with the laser device. I'll come to that later. But yeah, that's a special type of scanners. We call it as MR guided therapy solutions together. Whether it can give PET alone? Yes, you can. So basically, MR acquisition devices are here, PET acquisition devices are here. You just both put together. The data is coming in the two path in the system, in the computer. In the computer, they are get overlapped. You can still get the PET alone and MR alone. That's not a problem. You can get that. But that's not of no use. So we always need PET overlapped on any CT or MR image. So yeah, you can get the both. PET detectors are MR safe. Yes, there are some changes needed. Like the screws and bolts. Yes, that is available in the market. They are MR safe. Okay, any questions? I'll move on otherwise. Okay, I'll move on. Yeah, so this is one of the challenging situation I said. So in normal PET CT, we need something called attenuation correction, like how much of X-ray I can pass. I mean, to calculate that, I need the bone density information. That is something called attenuation correction data, AC, the AC data. Because with the PET MR, I don't have CT image. I directly have a PET and the MR, but I don't have the attenuation correction of the bone and the particular cross section. So to get that straight away, I need a CT. But here we are trying to overcome the CT, overcome the registration. So how do we get this AC or attenuation correction? There are different techniques people are following. One, they derive the synthetic CT. Basically, they acquire MR and they do AI convert AI or some other algorithm to get a CT like image from the MR. That is one way. Other way, I acquire normal MR sequences. It's called something called a Dixon technique, where I'll give a map of fat, water, like a four different types of image I will get. With that, I'll do some processing and get the attenuation correction. And the other option is I use ultra short T sequences. Basically, this is what bone imaging, with which I can get only the bone and I can calculate the attenuation correction. So the three ways, but it's still a little bit challenging with the PET-MR system. But people are overcoming with this, considering the other benefits they're getting. Yeah, the PET accretion happens in parallel to the MR. Both scan will happen, accretion will happen in parallel. So that's not a problem. That's like, oh, it's already solved, that problem. A typical protocol includes the localizer and the normal flare sequence, Pinnacle sequence, associated. It's like basic sequences. They just overlap the. So here the MR is not used for any findings for the. It's like a supplementary for the PET imaging. So that way, not much complex sequences are used. But however, the special sequences that helps to take care of motion, those algorithms will be used. For example, there are some acceleration techniques which includes compressions or arc. Some there are different techniques. So those benefits MR will use of, but that's for taking care of the motion management, nothing else. Yeah. Any questions on this before I go to the next modality?
Sir, you said about PET MR advantages.
Mm.
So, for which type of cases normally PET MR is used in a clinical practice in real time application as of now,
Yeah.
or it's such only?
No, it is in real time. So basically, the vendors like a GE Healthcare has a system, and GE Philips also has a system. Okay, there are two pictures I showed. One on the right is the latest one that is available with the GE vendor, General Electric. They have that in the product. People are using that. So all over the world, we have around 30 to 40 scanners installed all over the world, and yeah, it is available in hospitals, but not in India. But there are 30 to 40 scanners available worldwide. The one on the left is a old type of Philips scanners, but that was a little bit suspended now because you see the table was tilted. That was not effective, but so we stopped selling that machine.
What may be the unique specific advantage when you take separately MR, separately PET, and with PET MR?
Yeah, the advantage is with the doing PET plus MR, like all in one system. That has really an advantage, mainly because of the registration problem. The patient is not shifted between the machines, so that way the you can accurately register the PET deposition or the anatomical information that is really needed in terms of the diagnosis actually.
Okay, yes, sir.
Yeah. And yeah, approximate price that will be like in INR, it will be like a 30-35 crores easily.
Very
Yeah. Why we use PET CT is relevant when you have PET MR. Yeah. Why we use PET CT? Yeah. So again, PET MR is access is very difficult, very limited because of the cost. And in India, I don't think in India we don't have any system in India. So it's cost really comes into the picture. And how long usually take to develop this device? Yes, that is a good question. That that does not something that we do in short term. That takes ages, at least couple of years, I would say easily. and even 1 year, 1.5 year to develop, and another 6 months to get it clear, get it the regulatory clearance. Yeah, I'm moving to the next one. Okay, MR. Yeah. Okay, so here I'm going to talk about the MR only imaging, not the PET MR. So that PET MR is different story. That is used as a guidance or as a, for giving the anatomic information. Here I'm going to talk about the normal MR. Okay, I do normal MR from which what are things I can find that are related to the neurogenetic disorders. Like, is there any markers? Is there any standard pattern that I can do? I'm just going to cover a bit. Yeah. Yeah. So I would start with this list always. On the left side, you see different types of neurodegenerative disorders. I said there are many as is a group of disease, but and what is the protocol? If you look at the protocol is nothing but the different type of sequence. I'm not sure how many are aware of this. The T1, T2, or the contrast that they can get from MR. Like when I say contrast, how do you want to see the fat and the blood? If you want to see the fat as a white or like a bright, you need to do one picture that's called a T1. But if you want to see the blood as a bright, you want to do the T2. So that's the extreme, and the flare comes in between. Basically, this gives a different contrast, and the flare, SWA, DW are the different types of sequence itself. I can talk about that a lot, but for now, you take it as a different type of sequence. These are all very generic sequence, except couple of them. I would say SWI, DWI. So this is nothing but diffusions weighted imaging and susceptibility weighted imaging. So basically, you'll get a map of the function of susceptibility or the diffusion in that particular slice. The name, as the name says, when I say diffusion, so if I take the cross section of the head, like a full image of the head, I'll get a map of the diffusibility of the neurons, like are the blood vessels, how fast they can, how good they can they can carry the blood, how the blood flow easily. So that is the diffusion weighted. Susceptible weighted, nothing but you can say close to ion content, and they say that it's a marker. You can say that way. Oh yeah, I explained here. Sorry, I didn't see that before. I don't remember. Yeah. Yeah, I invited accessibility. Again, this is what I said in the previous slide. And yeah, what I missed is that there is something called a spectroscopy sequence. Spectroscopy sequence in MR will give an idea about the metabolites, whereas the normal MR will give the 2D image or 3D image, but the spectroscopy will give it's like a spike you will get. What is the metabolite in that particular region, in that particular slice? But what's the problem with that is very limited because of sensitivity. But in the higher field strength, we have in MR we have something called a field strength. That's that you can call it as a power of magnet. 1.5 Tesla, 3 Tesla, 7 Tesla. As in go with the higher the number, you get a more powerful magnet. In at least 3 Tesla, it is little bit okay, but 7 Tesla it is too good. But 7 Tesla is like a very costly system, so it's not used predominantly for this diagnosis. Yeah, I wanted to show a couple of pictures here. So the one on the top is a susceptibility weighted imaging, and yeah, it's occurred at 70 as you see here, right? 70. Yeah, there is a. I don't want to go into detail, but it's like a sample image. I can say it's very hard to interpret at this point of time. Like, and unless you see your experience with MR, it's very hard for you to differentiate or to appreciate. All the times it's showing is like this is MR images with which you can find the disease. So, for example, the one on the right is like a diagnosis of the Parkinson. You see the white spot, white line here, white strip. It's supposed to be black, dark. It's showing as a bright, so that indicates this is a Parkinson disease is there. Something like this. So this is another PSP is another type of neuro disorder where you see if you get the typically it's like a oval shape. It's like a butterfly shape we call it as typically, but here you see it's like a Mickey Mouse head. This part, which is not expected, and that's why they're saying yeah this has this particular type of disorder, that's PSP. Again, this is again diffusion weighted imaging. So diffusion weighted imaging is that's what I earlier I said, how good the blood vessels are has a diffusing capability. Yeah, if there is any disorder, and the diffusion will be restricted. And again, this is with the Huntington disease where the ventricles shows a it's become dark. It's not supposed to be. As you see in the right picture in the control one, it's all like a clear way, but here it's different. That's that. So it's marked as a disease abnormal. Okay, I go into the next section. I want to see any questions here. Did you foresee any solution that are in pipeline to address MRI compatibility of medical device? What exactly taken, especially implantable? Yeah, so when I say compatibility, implantable, it's a special question or interesting question. Earlier, like 5 years back, if you have any implant outright, you are rejected. However, now there are some special things available in MR. For example, flip scanner. You are allowed, provided if you have special type of implants. So suppose I'm going for a plate. At the time of implant itself, I can choose a higher end. It's a bit costlier. If you choose a higher end, you will get a spec sheet, data sheet with that implant. You have to keep it handy. Suppose after 6 months, if you are going for MR scan, the radiologist will look for that spec sheet, and if it is of that compatibility, you are allowed to do scans. So it's not like outright rejected. You are allowed with some exception. So at least MR is improved to that level, but it will be we don't see any line of sight to completely use all the implantable outright, but that's not possible. So we have moved a step where we can allow a part of the implants. That's where we are today. For Alzheimer and vascular dementia, you are using different pulse sequence. What are you really looking for? How do you differentiate? Yeah, that's what it is. Very tricky or like a radiology specific question. There is no predefined, or like it's only predefined, only small detail is needed to interpret the image, which needed definitely a study from a radiologist. I'm not experienced in that part. So they have a marker like I showed in the previous picture, right? So for the lateral ventricle, it is a normal one, but this is the different. This partition was not there. This is one indication, and here I see this is like a hypo. There's a white strip, it should not be there. So those are the markers you get trained as part of your radiology studies, radiology courses, and they will get to that. But not all people will know, can make it. It needs special skills. I agree with that. How about electronics PCB with respect to compatibility? Yeah, it's not outright excluded. Again, we have a classification there as well. Up to some limit, we can allow. See, for example, I think here the slides that I'm gonna show, you'll see a lot of electronics that is close to the MR. They are made such a way that doesn't impact the patient while scanning. There are some scans, there are some setups, there are some calibration you have to do while using those PCBs or electronics. If it meets the safety needs, then you are free to use that. I'll show some systems that helps you. Okay, I'll continue. Yeah. So I started with what are the generic neurodegenerative disorders, and then I picked up two and said the reason for that, why is it happening, and I a little bit covered on the diagnostic methodologies or the imaging methodologies, MR and PET MR. Now I want to shift the focus slightly in different way. Okay, you diagnose, what next? Is there a way to improve? In the beginning of the presentation, I said we can improve the quality of life. That is the therapy part. You can do something and improve the quality of life. I'll cover that here. We perform MRS general. What is the element you're looking for? Yeah, I know high level there are some metabolites, but I don't know in detail. I can get that for you. Okay. How many of you? I mean, I'm sure many of you heard about ultrasound imaging. Yeah, it's like a B mode, C mode, A mode, D mode, all those modes. This is the one you see is the ultrasound imaging. But when I say therapy, how the ultrasound can be used as therapy? How does it work? How does it possible? Because typically ultrasound beams goes through, get reflected and get received on the receiver side, you get the image. But there's a technique. Instead of passing parallel, if you focus the ultrasound in a particular point, that can be used as therapy, like you see in the picture here. The one on the top is a general imaging, a beam, three beams touching the tissue, and it reflected back, will get imaging. But instead of passing parallel, if you focus on a particular spot, this will have a higher energy, and that particular spot will get burnt. you can eradicate the tissue there. So this is a principle. It's used widely in the such treatments. It's called HIFU, high intensity focused ultrasound. Basically, if you focus ultrasound beam in a particular spot, you get the high intensity. And this technology is used left, right, everywhere. And the recent advancement is like usage in the neuro. I'll cover that later in the coming slides. But yeah, again, this is similar to the experiment that we do when I was a kid. I use the sunlight with the lens and burn the leaf or the matchstick. This is the same principle. You focus ultrasound beam, it gets higher energy and it gets burned that particular spot. Okay. Okay. I'll just give touch upon where all it's used. One, I said, yeah, this is a neuro treatment, MR plus HIFU device. This is called MR HIFU. 650 kilohertz is used for neuro. HIFU versus HFUS. HFUS stands for, I'm not sure, but HIFU stands for high intensity focused ultrasound. This is the neuro system. Incitec is a company who was pioneer in this work, and they recently launched with the neuro as well. They're like a front, they're a pioneer. There are other vendors in the market who does MR for other with the laser and other things. I'll come to that. But yeah, abdomen. There are other companies called Profound, but this guy is the pioneers here. HIFU versus found. Yeah, both are same. Okay, the ultrasound is also used in treatment, but with the guidance of ultrasound. That's, I mean, not so. Yeah, so this name looks a bit funny. Ultrasound guided focus ultrasound. So you are using ultrasound both for a treatment and both for a diagnostic as well, or guidance as well. So this is the two device. And you might be wonder, like you might be surprised to hear this. This is also used in a facial devices in a parlors. If you search for HIFU facial, they use a deep, like higher frequency, so that the superficial tissues will get burnt and it will regenerate. If there are black spot, it will get burnt and it will regenerate. Tissue will give a white polishing look. That's the principle behind that. It's also available. Okay, I'll come to the treatment part. Yeah, so at least the vendor, the Incitec who developed this solution, HIFU solution, they are targeting mainly these tremors, the Parkinson and essential. Both are almost similar. Again, this is same as the one I explained in the previous slide. For the Parkinson, you see substantia nigra. This is the region where the dipome is like lacking, and that causing that this issue, the Parkinson. And yes, essentially also tremors are more or less similar. It's in the different organ of the body. I mean, of the brain. So why do we need this? As I said, yeah, first they try with the beta blockers, or like they try with the medications or anti-seizures, deep brain stimulations. All those things will worn out beyond it. So at that point, they need something like this that will give a extended life with a better quality of life. That's when they need for this statement. How does it look? Is a normal MR scanner plus the HIFU setup. You see the sort of helmet here. This is the HIFU setup. And in the operator room, you see both the systems together. Here, this is like a HIFU system. This is the MR system. Both are next to each other. And they have a software interface, hardware interface. All those things been taken care as part of the development. How does MR used here? It's mainly used for treatment planning. You say, where should I? You can see in the picture. Where should I target? Where should not burn? All those details. And it has the device registration. Sub-millimeter precision control, because the image-based precision or the table movement, it's very precise control you will get. Continual treatment. This is a very key or benefit with MR. So I said focus ultrasound burn a spot, right? Suppose the tissue is the region of interest that you want to burn is this much. You cannot burn in one shot. You have to keep navigate to the different to do multiple times to burn the full part of the region that you're interested. So while doing that, I said the temperature rises. You should monitor the temperature during the treatment, during each sonication, so that there is no damage to the surrounding tissues. So that temperature monitoring is done by the MR imaging, normal MR imaging. That's a beauty of MR, this MR techniques. So sonication happens, MR happens. Yeah, from the MR image, we say the thermal map. Yeah, it is okay to continue. Then the second sonication, then thermal. That keeps on going here, this part. Once the entire tissue is burnt, we'll go to the post-treatment to see, okay, all done, all good, they can be discharged. I'll show a demo video here, like a simulated video. This is for the neuro exam, and this is the HIFU setup, and this is the normal MR. The patient has to be shaved, and there is a frame that is fixed on the head. That's called a stereotactic frame, and he's going into the helmet sort of thing that is called the HIFU device. So that contain like a helmet type. Yeah, you see that here. The blue color one of the ultrasonic array. So the ultrasound beams passes, it's focus at a particular point that got burned, and that gets repeated. Yeah, one thing you see is like there is a water circulation between the head and the ultrasound layer. The reason being is this is a skull, like a bone, thick, and yeah, ultrasound will the 50% of the ultrasound power that it pass that will get absorbed in the skull itself because of thickness of the bone. What happens is because of there will be heat in the top layer of the skull, so you cannot let it be there. So you take the heat out. So basically, it's like a normal ventilation technique that we follow. If it is hot, just pour a bucket of water. Same thing here. So you take away heat and continue with the next sonation. That is the next spot burning. This will be repeated until the entire region is burnt. Yeah, the one on the right is some sort of test. It happens in the middle of the treatment, or before and after, you can say. The one on the left is picture. There is a lot of shaking. They cannot do the circle, but whereas on the right side is like a post treatment. You can do that very much. There is no shaking there. And again, this is like a one-day procedure. You can walk out on the next day. That is like a beauty of this technique. This system we do have in India. We have like 5 to 6 systems all over the world. I mean, sorry, in India. We have one in Coimbatore and one in Chennai and one in Rajmundry, Andhra, a couple of them in Mumbai. Yeah, this is the before and after you can see here. This is of low degree, but this can be very severe as well. This is just an example. Yeah, so this is with the ultrasound, like a high intensity focused ultrasound with MR. It's not only ultrasound, there are other techniques available, like a laser treatment that's called laser interstitial therapy treatment. Again, but with the guidance of MR. I'll go to that. Any questions before that? Keep going. Yeah. Again, in the previous slide, you see the helmet setup that is part of the HIFU. But here, there is no helmet setup, but there is will like some sort of injector, some setups that puts a hole into the head. It's a bit scary, but yeah, not for light-hearted people, but yeah, it is what it is. It's a minimally invasive surgical procedure. Again, it's like it takes a day procedure. It uses a laser to heat and destroy the tissue there, so that we wanted to burn. Again, there are a couple of vendors in this area, like Medtronics and Montres. I'll show that. Maybe I'll show how system works. Yeah, again, it's the same. The MR system will be here. Next to that, there is their system, and they control from their system. And these are the two companies, Medtronics and Montres, who was there in the market. You can you can check the link for more information. And this is how it's set up. The electronics and everything is in the outside the magnet room. Only the cables will float around into the scanner. I'll show this video here. This was the brain tumor, epilepsy, brain tumor. I'm not sure if you can hear the volume. Yeah, first they do the positioning, they define the position, and then they put a small incision first, little incision, and inside which they pass the like an anchor, like to stay strong in that position actually, to align the trajectory. That's what they say. It's like doing the drill on the head. And then they put the cooling catheter, I mean cooling laser, because the laser it passes the heat, and as similar to the HIFU, after every sonication you should cool the layer surface, the surrounding area. This is the region I wanted to burn, I wanted to kill. And once the cooling tube is filled, the cover is taken out, just like a stylus. I mean, there are like that drive the cooling tube. You see the two tubes goes in and out. That's like a cooling one, and the top one is a laser. So this is a flexible laser catheter supported and with the cooling and the laser as well. So these three wires will be taken out. You can see that here. This is the laser will go here, and this is the for cooling. So these three pipes will go outside the MR into the room, into the technical room. It will be connected to the laser dispersal system, and this is for the cooling system. You'll see the images, but the MR is here. So as and when you do, the MR images are moved, and you can treat that here. They do the preparation. That is, so any guidance will come out of preparation, and that thermal map. Thermal map is about MR technique to find the temperature of the surface of any tissue. They set the temperature in that image, and they pass the laser. So the laser is passed through the tube that is taken out. This is the region I want, and this is the temperature I am setting. This should not exceed beyond this level. That's how I set, and it will be monitored during the treatment. So the one beam of laser is passed, and it like keep repeating. The process is repeated to burn all this region, entire tissue, the block or the region that I wanted to burn. Yeah, it is done, and patient is taken out. It's like a walk-in procedure again. Only the stitch has to be closed. That's all. Yeah, it's a walk-in procedure. They can walk out next day. Yeah. This is the laser interstitial thermal therapy, treatment therapy. Sorry. First for therapy to treatment of which disorder? Yes, it's all for essential tremors, Parkinson's, tremors. This is to minimize the tremor.
So whether MR lit can be a substitute for conventional therapy for brain tumors like other chemotherapy, other things.
Yes, yes, it is. It can be. It can be.
Okay.
Yeah, it is used for both actually. Yeah. Okay, I think that's my last slide. Any questions? Few researchers are working with fundus images. Fundus images, as in it's a modality imaging. I didn't get that. Or maybe I'm not expert in that part. I don't
Fundus
know.
image is to get the image of the retina to identify some retinal
Mhm.
diseases from a specialized camera called retinal camera.
Why not? See, basically,
Fundus camera.
okay, okay, the taking the okay eyeball thing. Yeah, see, there are research. It's all in the research level. I even come across today while I'm searching for the content for this one. People, there are some study in a group in University of Washington, I believe. They're trying to find Alzheimer from the gait analysis. So the gait analysis is like a walking pattern. It is the extreme case. It will reflect in the gait. But if you do the closer look and bring in AI and other things, you can find some correlation. Yeah, people are trying out all the other things, possible things, because the goal is to find as early as possible to have a prolonged life. If it succeeds, it is a wish, but yeah, I think it's all in the research stage.
Thank you, sir. The forum is open for questions. If you have any audience, if you have any questions, please.
Do you suggest any lifestyle changes that delay neurodegenerative disorders? I think you see mainly it is saying there's a wide notion that you should avoid the junk food because that is affecting the metabolic activity and that would cause other cell neurodegenerative disorders. That's why you see more in the US. People prefer the frozen food, ready-made food. But I don't think any statistical data or medical data to prove that. But that's a prevailing message in the community. I was wondering if some biomarkers can indicate dementia at a early stage. Yes, but we don't have any solid one. We even go to the doctors only when we get some symptom that is already late. And people are saying again the fundus image is one of such thing. So, but yeah, if you can find early, that is like a gift. Can we use first to reduce hand tremor by peripheral nerve stimulation? So no, I think you mean deep brain stimulation, not the peripheral nerve stimulation. That is alternate technique to reduce the tremor, but not peripheral nerve. That is something different. Acetylcholine concentration. I haven't heard of that. Sorry.
The question is incomplete. Sajita Nair, please.
I think the previous question was like if biomarkers can indicate the dementia. I mean dementia at an early stage. For example, acetylcholine concentration, I believe. But
I
sorry,
think beta amyloid. Maybe one.
I don't have
Excuse me,
experience
sir.
with it actually. Yeah, I can get back
Excuse
to.
me, sir. Sir, I think acetylcholine depletion is always accompanied with Alzheimer's disease. So if we can measure the concentration of acetylcholine, uh, maybe we'll be able to, can we able to predict Alzheimer's disease before cognition decline or before these gait changes and all these things happen? Can we predict something? Because acetylcholine has got a part on autonomic control as well. So can we think about something like that?
I remember seeing some papers on this, but yeah, I don't have any personal experience. I haven't worked on this type of studies, but I see some paper which is like a recent ones. We should try that anyway.
Yeah, I have seen that this acetylcholine depletion
Mhm.
shows a marked change in heart rate variability. So, but heart rate variability change is not exclusively due to Alzheimer's. It is due to many, it is implicated in many cases.
Okay.
So, I was thinking, can we identify some signatures, particularly for dementia cases?
Okay. Okay. Could be my because I'm not experiencing that one. Maybe yeah, I can get back on this one.
Thank you,
Any?
sir. It was really informative. Thank you so much.
Thank you. Thanks for listening. The late evening time. Any machine learning based biomarker for LED? Yeah, that is one of the research field. I think any neurogeneric disorder for that matter, any biomarkers if you find early, that is always a gift. People are trying on that one. Do you suggest innovators possible device? That is a need of an hour. But again, that is need. But on the other side, there is not much of that disease prevailing in India. So that kills the idea here. There. Even I have a device, where do I test it? Because I need to travel outside because I don't have much candidate in India. That was a challenge there. But yeah, if that can be extended outside of India, yeah, well and good. Why not? Inside MRI device, software Python or any other for image processing. So we don't have any separate any image processing software as in software. So we have the whole application software that does the reconstruction using a normal language. Now it's not a Python; it's a C++ only. It's like normal Fourier transform. So MR image is like only the software. We need the Fourier transform, the basic Fourier transform to get the image. And all the processing are like in C++. We don't use Python in the product mostly. How about detecting such disease from? Yes, I showed in the previous slide EEG. Yeah, it is one of the modality, but the challenge is with the signal quality. You won't get much with that. That was that was challenge there. But if we can detect only from EEG without any modality, any MR or CT, why not? We can try that.
Sir, we found from literature,
Mhm.
especially the PPMI dataset, which is universally used, Parkinson Progression Marker Initiative.
Mhm.
There, DAT scan is widely used uh, for Parkinson. How far in real time or in manufacturing wise in India, DAT scan is used, sir?
DAT scan is based on which technique?
Dopamine transporter imaging, DAT scan.
No, sorry, I haven't heard that actually. So,
Okay, so
so
it's
that's what like we are focusing on mainly on the MR side of it. So how can we bring in the more devices and more on the therapy side actually? And
Okay.
yeah, because whatever the sequences developed for MR, that can be used for other disease. That is other focal area. But yeah, this I haven't heard. Maybe I can check and get back on this one.
Okay, sir. Thank you.
Can you tell what are the mathematical concepts applied in this science? Believe me, it is not all what we study in the bachelor's or 12th. It is basic FFT, and not wavelet transform. Also, you will hardly see when only in the recent couple of years we are using wavelet transform for the once the AA comes. Before that, simple Fourier transform. That's all. Fast Fourier transform. Nothing beyond it. Okay.
Thank you, sir. I think that's all from the questions from the audience.
Yeah. Thank you.
Thank you, sir, for spending your evening time with us, covering a vast range of topics, starting from basic MRI-based image acquisition, PET MRI, MRS. Then you're going for diffusion tensor imaging, susceptibility tensor imaging, and also focused ultrasound that are all very new. MR, first, it's a very new term for us.
Yeah.
And we have also covered about MR lit. So MR lit, MRFS, these are all new areas which we have not heard.
We
Maybe
know that's
for the
yeah.
participants also,
Mm-hmm.
even MR PET.
Mm.
So you have started from basics, you have covered up to the recent trends. I hope we are all very much benefited. Participants also feel the same way like me. Benefited very much. Thank you, sir, for spending your valuable time with us and sharing your insights and experience. It's very difficult to get an experienced person like you for these kinds of FDP since you have worked in 20 years in MR images. So your insights and experience really helpful to us, sir. Thank you.
Yeah,
Thank you.
pleasure is mine, and thanks for the opportunity as well. Thank you.
Thank
Thanks,
you,
everyone.
sir.
Have a
Thank
good
you.
evening. See you, everyone. Bye bye.
Thank you, sir. Thank you.
Bye.
Thank you, sir. Thank you all participants. Thank you very much for your patient hearing. We will meet tomorrow sharp at 6:30. 6:30 our session 3 starts. Okay. Thank you very much.
Thank you, sir.
Thank you, madam.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, madam.